Hello, and welcome to Week 7 Highlights of Advanced Pathophysiology. Last week we learned about our immune system. The system can be activated in two ways, the classical pathway and the alternative pathway. Antibodies activate the classical pathway. We've learned that apoptosis is programmed cell death and that cytokines are mediators that help immune cells communicate. Interferon gamma released from the activated CD4 cells is the significant stimulus for macrophage activation. Macrophages and T lymphocytes are involved in cell-mediated immunity in which these cells directly attack targets. Cell-mediated immunity requires three types of cells: cytolytic T lymphocyte, antigen-presenting cells, and CD4 cells. Cytolytic T cells, or CD8, and helper T cells, or CD4, are key cellular immunity players. Helper T cells contribute to the immune response in three ways. First, they have an essential role in antibody production by B cells. Second, they release factors that promote type 4 sensitivity reactions, also known as delayed type hypersensitivity. Third, they participate in the activation of cytolytic T cells. B cells, lymphocytes have the job of making antibodies in humoral immunity. Autoimmune disorders may develop when the immune system becomes unable to discriminate between self and non-self and attacks its cells. This is made possible by major histocompatibility complex molecules, which play a role in the activation of T cells and are the basis of determining self and non-self. The immune system can damage renal glomeruli when antibodies bind to the basement membrane and initiate the immune cascade, activating innate and adaptive immune responses. When the antibodies or antibody complexes are deposited in the subendothelium basement membrane, complement proteins bind. The complement cascade can destroy the glomerular tissue and cause inflammation and swelling that blocks further blood flow through the glomerulus. In immune-mediated disorders, autoantibodies and antigen antibody complexes can filter through the glomerular capillary and bind to the basement membrane, causing renal injury. This binding to the basement membrane initiates the innate and adaptive immune responses, resulting in inflammation. The inflammation increases blood flow, which can elevate the glomerular pressure enough that damage occurs. In diabetic nephropathy, glomerular injury is mostly due to hyperglycemia. Glucose forms advanced glycation end products in the glomerulus and increases oxidative stress. While the immune system may play a role in making the injury worse, it is hyperglycemia that causes the injury to begin with. Diabetes causes chronic kidney disease because hyperglycemia leads to advanced glycation end products in the glomerulus and an increase in oxidative stress accompanied by immune activation. Inflammation and hypertension related to diabetes are also implicated in diabetic nephropathy. Hypertension nephropathy occurs when blood pressure is consistently elevated, leading to the pathological wall thickening of the renal arterioles. Hypertension promotes hyperinfiltration, and this overload initiates slow deterioration of nephron function. The kidney receives far greater blood flow, about 20% of cardiac output, than its size and weight. There are two mechanisms used by the kidney to maintain blood flow despite changes in blood pressure. The myogenic mechanism relies on smooth muscles' ability to contract in response to stretch. When the blood pressure increases, this stretches the renal arterioles, which respond by contracting. Vasoconstriction reduces the amount of blood flow to the glomerulus, preventing an increase in glomerular hydrostatic pressure. When the blood pressure drops, the sympathetic nervous system stimulates vasoconstriction of afferent arterioles. This causes a reduction in renal blood flow and maintains glomerular hydrostatic pressure. Nephron hyperfiltration occurs when nephron loss causes increased filtration rate of the remaining nephrons. Intrauterine growth restriction, premature birth, and low birth weight all reduce the initial number of nephrons. Additionally, nephrons do not develop after birth, and nephrons are continually lost at a slow rate throughout life. Disease processes that secondarily damage kidneys, such as uncontrolled diabetes and hypertension, can accelerate nephron loss and cause earlier hyperfiltration and additional nephron damage. The most common causes of kidney diseases are systemic. Chronic kidney disease is a common consequence of diabetes mellitus, up to 50% of all chronic kidney disease cases, and hypertension, about 25% of the chronic kidney diseases, or both. Acute kidney injury is most common in critical care settings due to hypovolemia and hypotension from causes such as sepsis, trauma, and acute heart failure. Nephrotoxicity from medications, hemodialysis, or hemolysis, hemolysis or rhabdomyolysis is an additional source of acute kidney injury. Urine blockage from kidney stones or neoplasms is the third source of acute kidney injury. Acute kidney injury may resolve with treatment that is a risk factor for later chronic kidney disease development. Chronic kidney disease is also a risk factor for subsequent acute kidney injury. Urine albumin, creatinine ratio, and estimated glomerular filtration rate values are used to stage early kidney disease, while late stages are assigned based on estimated glomerular filtration rate alone. Estimated glomerular filtration rate is the best test to measure your kidney function levels and determine your stage of kidney disease. Other findings to monitor include increased BUN and creatinine, hypertension, hyperkalemia, acidosis, anemia, metabolic acidosis, and chronic kidney disease with material and bone metabolism. The reason these tests is for the end-stage renal disease that is manifested by these consequences of kidney disease. The CKD MBD, which is the chronic kidney disease that is commonly associated with disorders of mineral and bone metabolism, manifested by either one or a combination of the following three components. These are abnormalities in calcium, phosphorus, parathyroid hormone, fibroblast growth factor 23, and vitamin D metabolism. Abnormalities in bone turnover, materialization, volume, linear growth, or strength. And then you have the extra skeletal calcification. The work of the GI system and its associated organs such as glands, liver, and pancreas requires exquisite coordination between segments. Enteric neurons coordinate motility, and peristalsis are responsible to local gut sensory signals and subject to auto, um, autonomic control that coordinates gut activity with the other um, uh, challenges of the body is facing. Gut hormones coordinate the activity levels of different gut segments with gallbladder contractions and pancreatic secretions. Local mediators sense the presence of food, acid, digestion products, and modulate activity accordingly. The gut immune system functions to protect the body from ingested pathogens and toxins. Pathogens can enter the body through the ingestion of food and drink and can be detected and defended against quickly due to the gut immune tissues. Microorganisms that have a commensurate role in the human body stimulates immune defenses to protect against systemic infection. There are three main stimuli to the gastric acid secretion. The vagus nerve releases acetylcholine as meal begins, starting the cephalic phase of acid secretion. As food enters and distends the stomach, particularly the antrum, the hormone gastrin is released from the endocrine cells and circulates to the parietal cells to augment the acid secretion. Gastrin also stimulates the histamine section from the local enterochromaffin cells, and histamine synergizes with gastrin and acetylcholine to reach the maximal acid secretion. As the stomach empties, acetylcholine, gastrin, and histamine levels drop, and prostaglandin, among other signals, increases and inhibits gastric acid. When the stomach acid is excessive or prolonged, the gastric epithelial cells can be damaged, and ulcer formation can occur due to the mucosa's corrosion. The gram-negative bacteria H. pylori can live in acidic environments, and cytotoxins it releases breaks down mucosal cells and can cause recurrent gastric ulcers. The duodenal secretes pancreatic juice with proenzymes for digestion of carbohydrates, proteins, and fats. This is the primary source of chemical digestion. The liver and gallbladder secretes bile, providing bile salts that are needed for fat absorption. The jejunum is the longest segment of the small intestine and conducts the majority of absorption. While the most significant amount of absorption occurs in the jejunum, the terminal ileum is responsible for the absorption of vitamin B12 and bile salts uptake for recycle. Carbohydrates are broken down into monosaccharides that can be absorbed by transporters. Polysaccharides are broken down into disaccharides and monosaccharides by salivary and pancreatic amylase. Disaccharides are broken down into glucose, fructose, galactose, and maltose. Proteins are digested beginning with pepsin secretion in the stomach. Pancreatic trypsin, chymotrypsin, and carboxyl peptidase are activated from secreted proenzymes and broken down proteins into amino acids, dipeptides, and tripeptides absorbed by membrane transporters. Lipid digestion begins in the mouth and stomach with lingual and gastric lipase. Fat droplets in the duodenum are mixed with bile and coated with amphipathic bile salts. Pancreatic lipid lipase pancreatic lipase breaks dietary lipids down into monoglycerides, fatty acids, lipofphospholipids, and cholesterol. Intestinal epithelial cells rejoin fatty acids and monoglycerides, producing triglycerides packaged with cholesterol and phospholipids into chylomicrons absorbed by gut lymph vessels called lacteals. Chronic disorders of the small intestine impact absorption of sugars, amino acids, water, and fat-soluble vitamins, fatty acids, vitamin B12, iron, and calcium. Chronic disorders of the large intestine will impact water absorption and fluid and electrolyte balance. With either type of disorder, homeostasis will be disrupted. However, the small intestine disorders will most likely impair nutritional status, while large intestinal disorders can significantly impact hydration status. This concludes week 7 highlights of pathophysiology. Until next time, see you in week 8. Thank you for watching.